morning, everyone. Welcome to our session for AWE, Association of Women Endoscopists. And I'd like to start off to thank the team, the AWE team, for allowing the opportunity to educate globally. And we coined this global medical outreach mission a few years ago. And even from the start, many years ago, when Dr. Krinsky did her first LAMS case and put in the first Axios in Vietnam, and subsequent to that, the hospitals are now doing the Axios procedures. And you're talking about a country of 95 million, and to have made this difference really impacted our program, our organization. From the first, also Spyglass, ERCP, Dr. Riker did in the south of Vietnam many years ago. We were so successful that we've had recurring years. And today we're going to show you our experience from this last adventure we had. And we thank our team, Dr. Tyberg, Dr. Cork, Dr. Branch, for coming along with us. We have many stories to share with you today. And it's been a very rewarding journey for all of us. Thank you. We'll just jump right into the program.
And we'll have everyone introduce themselves. So can we start with Dr. Tyberg, please?
Sure. Hi, everyone. I'm Amy Tyberg, interventional endoscopist at Hackensack Meridian Health in New Jersey, and so honored and excited that I was able to participate in this Vietnam trip this year. It was really just a wonderful experience, and I'm excited to talk about it with all of you.
And Dr. Cork is here, but I cannot see him. So maybe have him introduce. Oh, here he is.
I should be here.
You should.
Hi, everyone. I'm Dr. Paul Cork from Hoag Hospital in Newport Beach, California. I've had the real pleasure and honor to be on 3 of these Vietnam trips, and I'm really excited to share our experiences. Thank you.
Thank you. And Dr. Nguyen and Dr. Krinsky.
Oh, I'm Phoenix Nguyen, endoscopist at Hoag Hospital, also with Dr. Cork.
And co-founder of Association of Women Endoscopists.
I always forget that part. Dr. Krinsky.
Yes, hi, Mary Lee Krinsky, advanced endoscopist at University of California, San Diego, co-founder of AWE with these wonderful ladies, Dr. Riker and Dr. Nguyen, Sonia, Phoenix. And it's been quite a journey. And this part where we do our global medical outreach missions has been, I think, one of the most rewarding parts of AWE.
And Sonia Riker, I'm interventionalist at Harbor UCLA Medical Center. So shall we start?
We have Dr. Laurel Branch.
Yeah, I'm so
Laurel.
sorry. Laurel is going to be, I cannot see her. That's fine.
Hi, I'm Laurel Branch. I'm the Advanced Endoscopy Fellow at UC San Diego. This was my second trip to Vietnam with AWE, and I've really enjoyed the opportunity to work with this group during my fellowship.
And we're hoping that she's going to join us as a member when she starts, when she transitions from end of the training to the what we do on a daily basis and acquire some more gray hairs. Yes, that's the plan. So shall we start?
Yeah, I think it's a good time to start. This is something different that we've done in the past, but we really wanted to share this amazing experience with everybody who attends our annual interventional endoscopy course. And I thought it would be an opportunity just to talk to, especially Amy and Paul, and understand more about, what motivated you to join this mission in Vietnam and what were your expectations going in. We've done it already 3 years, so we kind of have an idea. Oh, Paul, actually, you've done it 3 years. This one goes to Amy.
Yeah, I would have loved to have done it for 3 years too, but but last year, unfortunately, I had just had a baby, so the timing didn't work out. But I was so excited to be able to join this year. I think for me, I love, trips like this combine two of my passions. One is medicine, and the other is travel. And it's so exciting, one, to be able to see and experience a new place, but more importantly, also to bring medical knowledge to a new place, and also learn from the learn from the physicians that are there as well. And I think there's really, it kind of, when you do trips like this, I really feel like it reminds us, and me definitely, why I went into medicine in the first place, which is really to help patients, and try to you know expand, any way that we can expand the number of people that we're helping by bringing new technology, or new education to a place that otherwise wouldn't have those opportunities. It's just so rewarding, and I just cherish every opportunity to do that.
Yeah, thank you. I mean, I guess this is, quite a unique experience. Paul, you've been at 3 of these courses presenting live cases. What is it like presenting live cases and working alongside these anxious, and not anxious, but these physicians that are so thirsty to learn new technology? What has your experience been?
It's been really fun and exciting. I remember one of the cases doing an EUS and just passing by the gallbladder, and they all got excited. There's the gallbladder on EUS, and to see that energy and enthusiasm from doctors kind of learning new procedures and new techniques is really a rewarding experience for me. And then also just the teamwork that goes into it, and bonding with the group that travels and having that experience has been really a pleasure.
So our courses have, they include not only the live cases, but we have a didactic part, and we also have a nursing course the day before, just for the audience that may not know exactly what we're doing. Any takeaways or impressions on how it was presenting and the questions that the audience asked during your cases? I think for the last, gosh, maybe two years, I've been up in the operating rooms and haven't really had the opportunity to experience that energy in the audience.
I can take that one. I was down in the auditorium during some of the cases, and I will say that I was so impressed by the questions that were being asked, both during the live presentations as well as in follow-up to the lectures. It was so clear that the physicians there paying were really fascinated and interested in what was happening, and what we were talking about and what we were doing, by the quality of the questions that were being asked. And they were really genuinely interested in learning more about it and understanding, what all of what we were doing and saying. So it was, again, I think, just a reminder of how great medicine can be when we all learn from each other, and there's really just a forever drive for learning, no matter where we are, in our careers. So
I think we also get bugged, like every day we have, especially in the current day of medicine here in the US, we get bogged down in so much of I don't know what word you want to use, minutia or EHR stuff. And I'm sure we all have our list of things to do that we checked off every day. And I think those trips for me, give an opportunity. This is not about the list. This is not about, and I think for us too, so much planning goes into it, and we have all this checklist to make it happen. But then when you get there, that list goes away, and that allows you just to focus on what's in front of you and trying to do the best you can. I also wanted to, I'm glad, I know Dr. Nguyen has a very busy morning, but she's still able to stay here for a little bit. because this is actually her vision. And I do want to ask her what made her think of that, because she brought this to life, and so because of her, like, how did she come up with it, and what was she thinking to accomplish?
I think growing up in the field of endoscopic ultrasound, I always had the dream of bringing it to the country where I was born. And the organization provided the opportunity for me to do so. It's been my dream probably for 20 years now. And I knew that, the technology wasn't there. Some of the countries in Asia, particularly Vietnam, may or may not have the equipment, but didn't have the resources, the human power, the expertise to get it up and running. And even that one day that we come to teach, we saw, because we had follow up, and they pick it up so quickly. They're so smart, and it's been extremely rewarding. It's just been my dream for many years, and I can't thank you, all of everyone who's on the video today, for making it happen.
Thank you, Phoenix, for bringing us along for the journey. It's been amazing. I don't know, maybe now is a good time to share our experience in Da Nang at the University Hospital Medical Center, where we were able to teach some procedures, and we could share those. We have one of the challenges always when we go abroad is how to record and how to share these experiences. So we have some limited video and limited photos, but we'd love to share the cases. Shall we delve in? We have Laurel Branch here, who's the advanced fellow at UC San Diego, who has been along for the journey and was able to aggregate and put this presentation together. So I'd love to have her share. And I don't know if you wanted to make any comments right as you're getting the presentation ready on what it's like as a fellow to go abroad and have that experience.
Yeah, I would say it's been a really cool opportunity to see, as you're learning these procedures, how they're being taught and bringing these, to a different part of the world, seeing different endoscopy units and how they function, has really kind of broadened my horizons. Starting with the presentation, this was the first day when everyone was able to round with the physicians in Da Nang and see some of the patients and talk about the cases that would be done for the course the next day. Dr. Krinsky, did you want to share anything about that experience?
This was the first time we ever had this opportunity to walk through the wards, and it was just fascinating seeing how I hope it's not poorly perceived, but they're teeing up the patients. They have them ready for the cases. They're in rooms of, gosh, maybe 4 to 6 patients in a room. They're very enthusiastic to share their story and what's going on, and interested and very accepting of us coming from another country to help them. The physicians were quite knowledgeable, experienced, and it was similar to rounds, in a hospital. Going into the room, you can see the physician over there with the laptop with the cases, and we discuss it and go in. But it was really quite an experience to see the patients and have that opportunity that we had never had before. Sonia, what did you think of this experience?
I thought that was very interesting. It does put, I think it put in perspective for me, and maybe allow me to appreciate more what we have here.
Was there anything that surprised you?
Well, I didn't grow up in this country. I wouldn't say it surprised me and brought memories. It's a lot of patients in the room. It's sometimes probably I've seen 10 or plus in some rooms. It's challenging, and so although everything seems to be similar in some ways, but also just basic creature comforts are not always there. And I know And we're very grateful for that. I know some patients waited for weeks in there for us to do the cases. Yeah. Shall we move forward?
Yeah. Diving into the first case, we had a 76-year-old male with a history of cholelithiasis, had a cholecystectomy 10 years ago, and a bile duct exploration surgery for choledocholithiasis 5 years ago, as there were no endoscopic options available at that time. Came into the hospital 1 month before our arrival with cholangitis, had ERCP with plastic biliary stent placement, but there were still large stones. So our plan during the course was to do ERCP with cholangioscopy to further address this.
I think we have some next slides, right?
Yeah, so we have a few more of the CT scans that were obtained, and then some of our fluoroscopy images.
So before you could see the stone burden on the CT scan, and here on the cholangiogram, you can see the tremendous stone burden with those filling defects. And right,
I don't
Dr.
know
Reicher?
if, yeah, I don't know if you can appreciate it, but the stones, like we could see the ones that are more proximal that are large, but exactly the same size are all the way from the papilla up into bifurcation. They're like nicely 2 or 3 stones that are aligned like beads on a necklace, just the really large beads, I think.
I don't think I had ever seen such a tremendous stone burden. And then when we put that spyglass cholangioscope into that duct, we were greeted.
Yeah, and this is, I just want to show you, I don't know if you see my pointer. This is Dr. Nguyen, who is a surgeon and interventional endoscopist at Da Nang. And here, I think this is Dr. Krinsky's sort of from behind. And we're very fortunate that several nurses and a tech from Ho went with us, and that made well, first of all, they're so outstandingly experienced that makes in any institution working with them is always a privilege, but yeah, working in Da Nang with them made the challenging cases even better. And this is the rest of the team. I believe this is a nurse from Vietnam, and I think this is part of that's my ear and my head. So trying to figure things out. So let's. And then we're trying to work with, I think, Spy Basket on this. And I think we have a video of it too. Oh yeah, that's Dr. Krinsky breaking this.
What was your experience working with Dr. Nguyen? I mean, trying to introduce this new technology. I know he was very, very keenly interested. They have a number of stone cases that it would benefit, as he shared. However, he was somewhat tentative, so it was an experience, introducing this technology to someone who's already experienced at ERCP. What was your take on that?
I think that he would for sure, he has a lot of skill. He's been working for 10+ years, and as with any new technology, and here's your expanding the opening. And of course, the papilla was alongside 2 ticks to make it even more enjoyable. And this is the laser probe coming in, and Dr. Krinsky is, what is the word, trying to mine this with this thing. So I think one thing that made me think about this case is what we don't, at least what I don't think about on a daily basis, is how do you organize your room? And I'm going to ask Dr. Tyberg and Dr. Cork how to do these cases. How do you like your room organized? What do you have how do you want it set up? Because in this, what made it challenging is that things that we don't think about, the fluoroscopy wasn't in the same plane of vision as the SPY image. The length of the probe we picked was too short. So each time we moved, it pulled it back. Every time we're ready to shoot, we pull it back. So for both those little things, like we didn't quite know what the settings are, weren't the same. So tell us how both Dr. Tyberg and Dr. Cork, how do you like your cases to be done with the large stone burdens? I will start with Amy.
Yeah, I mean, I think, whenever you're using a new technology, there's always going to be, it's never going to be set up exactly the right way. It's hard to think of every little thing in advance. So, I think the first case of any technology, whether you're in Vietnam, whether you're in the US, is always a little rougher. And the more you do, the more, the smoother it gets. But I think you're right. Ergonomics are becoming a big topic in endoscopy. We're wearing very heavy lead, and we need to do everything we can to avoid injury for ourselves so that we can continue to treat patients. And so having the screens in a position where you don't have to be turning your head, 180 degrees the other way to see the fluoroscopy is important. So yes, I like to have I have two screens. Usually I have the cholangioscopy image and on one screen with a small picture-in-picture and a small image of the endoscopic image in the small picture on that screen. And then I have a second screen with the fluoroscopy image right next to it. And I recently changed institutions, and I do all my ERCPs supine. So all the monitors have to be sort of opposite position to what they were used to when the other interventionalists do their procedures prone. So we had a lot of discussions about room setup and how to arrange things when I started, because as you know, when you do your patient supine, you end up having your back to the patient. So you need the screens on the right, on your right side near where where all the machines, where the scope plugs in.
Yeah, Amy,
Module. I couldn't think of the word.
Would you mind sharing, because that is a very common problem I run into when I have new physicians joining our institution and have different practices. How do you solve it when let's say everybody prior to that were prone, and let's say people come and want to do supine?
Yeah, I mean, it's a great question. It's a lot of discussion, and but ultimately what we did is we got a second monitor. So so the fluoroscopy could be transmitted to a second monitor so that I didn't have to have it on the actual fluoroscopy machine monitor, which is generally on the other side of the patient with the CR.
Right.
And then
you bring it in for the days when you do procedures.
Yes, actually, it lives in that room, and it just is pushed out of the way unless there's a ERCP case for someone that's doing it supine, and then we bring it out for those cases. But yeah, I think your points are critical. It's important to talk about it ahead of time because, as I said, ergonomics is really important, and it's no longer acceptable just to suffer and end up with injuries to your back or to your neck from turning around and not being able to see what you need to see easily. So I think it's whenever you're joining a new place or doing procedure somewhere new, it's important to have the discussion and talk about how to set things up to make sure that you set yourself up for being the most successful that you can be.
And for you guys, since we're talking about breaking large stones, how do you, well, we were a little bit surprised. It might not have been a great choice for the life course, because, when you go to a new country, we didn't know too far ahead of time what cases we're going to get. So we just do what the local physician wants us to do, but might have not been a great choice for a live event. But how, and the question to Paul, how do you set up your day when you anticipate this kind of large stone cases that you know going to take time?
Well, to touch on the first question just briefly, to add to what Dr. Tyberg said, I think you also hit it earlier, Dr. Riker. We have such an abundance of resources in the US. So our rooms have dedicated fluoroscopy machines and 4 monitors hanging perfectly. We're lucky, I think, in the States and particularly at Hoag. And then we're also lucky, you touched on this earlier, our nurses and techs are really experienced and good. So I think we have that advantage for room setup, equipment setup, difficult cases. And one last thing just to add to that quickly is like the help from industry. You know, when you are doing a new case, it's really helpful when, you know, usually the companies have great support and are able to provide it with their representatives. So that all goes into room setup and tackling new or challenging cases. For large stones, I mean, try your best in advance to know what you're getting into, but that can always be a challenge when it's a busy day or it ends up being an inpatient at the end of a long day.
Live course.
I don't know if there is a great answer there, but
Do you
you know,
try
you do
to
your best
schedule?
and try
Do
to.
you try to schedule them towards the end of the day if you know that that is coming?
Yes, if I know in advance that there's going to be a burden of stones, like in this case, I would try to put it at the end of the day because even though we all might be a little tired at that point, we try to minimize the disruption to the other scheduled cases and just try to do as much as you possibly can.
And I'm gonna just ask a few kind of rapid questions to everybody. Kind of like those whatever shows where they ask you one or the other. Amy, EHL versus laser preferences.
That's a hard, rapid question to answer. You know,
You
I
can
think
answer longer.
in a case like this, I think laser is better. It's a little bit stronger, more powerful, and I think you can work a little bit faster breaking the stones into pieces. However, EHL is more readily available, easier to set up. You know, the laser does take some coordination, not something you can really do last minute. So both have their places, and EHL tends to work very well too. So yeah, I didn't really answer yes or no, but
No, you got the perfect Switzerland answer. You answered both essentially. Paul, preferences, EHL or laser?
I'll just say EHL. Same reasons Dr. Tyberg said, but kind of preference there.
But why?
Why?
Yes.
Maybe not as quite as powerful focally, but gets a little bit more diffusion in the water, and I think don't have to be as pinpoint when aiming at the stone, and will kind of diffuse and break the stones a little bit more quickly, in my opinion, in most cases.
Mary Lee, you cannot be muted. She's muted.
Oh, I'm muted on purpose. I think listening to Paul and Amy is good enough. I think Amy brought up some good points about the laser, and so did Paul. I'm going to be Switzerland.
Oh, come on, Phoenix.
Well, no, I think Paul made a pitch to our industry partner, and we can't do this course and everything that we do daily without them. And this year we had 2 particular big companies that supported what we did. And just a shout out for Boston and Fuji for supporting the course. Also, an important point that we didn't bring up is Dr. Cork brought back equipment, accessories in boxes to hopefully, you know, cover the missing pieces that we didn't have during the course. Of course, you know, we can never predict what we'll need. But bringing those supplies back really helped to make the cases happen.
Oh, that's a great point. And I think both of you made a point with that kind of stone burden, you can quite expect it to finish in one sitting. So you have to be prepared to come back, otherwise cases become too long. And we actually talked to industry to bring the equipment back to Da Nang and hopefully complete. And we're available to Dr. Nguyen and the team to complete. And I think they're planning to do that. That is a plan. But one more yes or no questions, and then we'll move on. Are you so normal saline or sterile water for cholangioscopy for breaking this down? Emmy?
So this one, I think we're all going to be in agreement. So you have to use saline for EHL in order for the actual technology to work. I only do that if I'm going to be using EHL, although I know there are some places that will routinely for every ERCP change to normal saline.
Paul?
I'll go out on a limb and say it doesn't matter. I don't know. I hear people say that, but unless my techs are secretly changing it to saline, I've been using water and been doing fine.
Oh, so interesting.
I have a bad joke.
It's not supposed to work.
It's called electrohydrolithotripsy, not electrosaline lithotripsy. So,
Mary Lee?
I think saline is ideal, although I do know that I've used water before too, and it seems to work. But we were using saline here. We made sure we had saline.
Paul, I actually used water for years, and then one day I changed, and I saw significant difference. So
I am shocked. I thought we were going to be
yes
across the board here. Yeah.
No,
West Coast, East Coast.
Yeah, no, but I changed, and I think Emmy, you win. That's what it is. So I think we're gonna move. It was a long case, but we are gonna get moving to the other one.
Yeah, this was our next case. We had another ERCP, a 70-year-old with choledochal lithiasis, had an ERCP with stent placement 5 months ago and came to remove the stent and make sure there were no remaining stones. I think that was kind of the CT images we had. Dr. Krinsky, did you have any experience from that case?
Yeah, I think that was Laurel. We should ask you because you did. We should ask,
that's right. My experience was passing the baton and having my advanced fellow do her first live case. How was that?
It was really cool. I really appreciated the opportunity to get to do a case and participate with the endoscopy this year. It was a lot of fun, and I knew that I had lots of good mentors right there to help me if things got tricky.
I mean, this was also a case, right, that was a stone pitched case to us with a stone, and we thought it would be a spyglass case, but it really wasn't. There really wasn't much in that duct. They had already taken care of everything. So
I think it was a small fragment came out.
Right, in big contrast to the prior case.
Oh, that was a relief.
It just makes the point that sometimes you can get away if you have a large stone that you can't remove at the time of ERCP. Putting a stent in and then coming back often is enough to treat the stone. Actually, just the pressure from the stent and the wall, puts enough pressure on that stone that it breaks it up. And it's not that uncommon. My fellows are all disappointed when we have a big stone case that we've stented in the past and the patient comes in and we're all set up for laser or EHL. And then it turns out you pull out the stent and the stone has already fragmented and all the pieces come out and there's no need for any of those advanced techniques. So I think, when we were talking about scheduling earlier, if you end up surprised by a case that has a huge stone burden, you can work a little bit on it, but it's never wrong to put a stent and, schedule the patient to come back and book a longer period of time, knowing that sometimes stent placement alone is enough to fragment a larger stone. Not
And
like the first case that would a stent alone wouldn't have done the job, but in a case like this.
and along those lines, balloon dilation. We all know about it, but I think sometimes some people forget about it too.
No, I think it's a great point.
Yeah, no,
I-
balloon sphincteroplasty is great, right? When you have one large stone and you can just be one and done.
Mhm.
Yeah, and even for Mary Lee, you actually started that large stone case, and the first thing we did is to dilate to try to optimize our sort of exit
Right.
strategy.
But also
Now,
making sure you first have a little of a sphincterotomy because you don't want to put too much pressure on the pancreatic duct because there's definitely an increased risk of pancreatitis when doing balloon sphincteroplasty. Just adding that.
Yeah, and then just to finish this case and our biliary cases, I wanted to ask Amy and Paul, and obviously all of you, where do you think cholangioscopy sort of moving forward? What are the new avenues? How do you use it differently from what you've been using? So what are the new lens you go after nowadays? Anyone? I've been badgering Amy. I'll start with Paul.
I don't know if there's anything particularly new, but I think it's just getting better. So we have better optical visualization with the scope. As the equipment improves, we have better success at passing tools through it, which I think can lead to bigger biopsy forceps. So I see it being used perhaps more often and earlier because it can be really helpful. I'm thinking particularly for strictures and getting sampling. For these big stone cases with laser and EHL, you really only need a very small fiber or probe to go through there, and you can be successful. But when we're trying to optically diagnose a lesion, get a
Just
sense if
hold
it's
on
benign or
that.
malignant.
I'll ask you for the next case, so don't give it out.
But that's where I think it's the improvements are going to give us a lot of benefit.
Do you feel that I guess you going after maybe stones that were before in a more challenging location, intrahepatic, cystic duct, to both of you, Paul and Amy?
Yeah, I agree. I think, the cholangioscopy is going to become more and more routine in our cases, especially as we get new cholangioscopes, like, for instance, smaller French diameters, which will allow us to go higher up into the intrahepatics or in the pancreas more easily, or larger working channels, which is going to give us better tools. And I think that the indications are going to be similar, but the applications are going to expand significantly. We're going to be using it in a lot more of our cases, I think. And also the when we get AI in cholangioscopy, I think just in terms of diagnosis, that's also going to expand the indications as well, and tissue targeting.
Hold that thought, and we're going to go to the next case.
So switch gears to EUS focused cases. We had a 42-year-old with a subepithelial lesion in the fundus that was found on a prior endoscopy. We had those images, and then we planned EUS for further evaluation.
I think, Phoenix, you were in that case, right?
Yes. I
With
think,
Dr. Chang, right?
yes. So, is there a next slide, or this is the
That was all we
EUS?
had from that case, I believe.
Yeah, so the lesion was, it looked on endoscopic ultrasound to be a stromal tumor. And so, Dr. Cork, can you share with us your thought on FNB and biopsy? What needles would you use, and what's your approach for a submucosal lesion in the stomach?
If it looks like it's fourth layer, like a stromal tumor, I'll often try to do a needle biopsy. I think it has to be large enough so endoscopically this lesion looks potentially a centimeter, maybe less. But if it's 5 millimeters or smaller, then I don't think we're gonna get much tissue with a needle. And it's probably not so significant anyways. But um, with the core needles, we can usually get enough of a sample to make a diagnosis. So I like to do that. If that's not an option or non-diagnostic, there are a host of other ways to try to get tissue, whether that's just deep deep biopsies with a forceps, or even making an incision over it, or even resecting it if it's very small. And you really want to get it removed and get the diagnosis. Although the utility clinically may not be necessary in a lot of those cases. But bottom line, yes, I do like to try to get a needle biopsy if I think it's feasible.
Amy, what are your thoughts on that?
Yeah, same. I think we're going to be in agreement here. I try also to get tissue ahead of time. Just you never know. Things can look one way on EUS, and most of the time they are what you think. But every now and then there's a zebra that pops up, and it's nice, before talking about removal to have a sense of what the lesion is.
We can go, for the interest of time, we can go to the next one.
Yeah, this was a 74-year-old male admitted with abdominal pain, had a CT with a cystic lesion in the pancreas head, measuring 22 by 28 by 55, and irregular walls, some internal septations. The pancreatic duct was dilated to 9 millimeters. The suspicion was for main duct IPMN, and so we were going to do an EUS and an ERCP with pancreatoscopy. So here's some of our CT images. And then here's Dr. Cork as the case gets started.
So Dr. Cork, I believe this was, it looked like a main duct IPMN on EUS, and this is you doing ERCP.
Yeah, we have a video of both the US and the ERCP. So
Excellent, because I remember this case really well because it was such a classic example of main duct IPMN here on EUS. Seeing the frond-like projections and the nodularity along the wall. That's the main duct IPMN. That's a very dilated pancreatic duct.
It's huge.
And the duct dilation extended all the way out to the tail of the pancreas, although we didn't see the projections and the nodularity extending out there. So perhaps the worst part of the disease was isolated to the head, or so we felt. And that's where pancreatoscopy can be helpful in delineating the extent of the disease.
So we can show the next video. And I think I remember one of the surprises, I don't know if you could see like the image on the side, that the minor papilla, not just the major,
Right.
The minor had a fish mouse appearance, which was amazing.
Right, that was really neat to see. Not something you see too often.
Right.
And again, on pancreatoscopy, it had the classic features, and you're seeing some of these projections and nodules coming off the wall of the main pancreatic duct. One of the things we try to assess for, I think this is maybe what Dr. Riker was alluding to earlier, is this dysplasia? Is it malignancy? We didn't see any overtly malignant appearing nodules. There wasn't anything with a very high degree of vascularization. The real challenge in this case was, I think, the duct was so dilated and made a big turn at the neck of the pancreas. We weren't really able to get the scope as far as we would have liked into the pancreatic body, because that's where we wanted to, again, assess the proximal extent of the disease. but nonetheless, we got some really amazing images of in the head of the pancreas.
So Paul, that touches on, the rationale for doing pancreatoscopy in these patients with main duct IPMN, trying to define the extent, and then also bridges to what Dr. Amy Tyberg was saying about newer technology in the future with the thinner caliber scopes and different designs that maybe will let us go beyond the neck of the pancreas, because it can be
So
quite challenging,
what
even
is
in the
the
dilate.
tips and tricks? What is the tips and tricks? You use both Amy and Paul for pancreatoscopy, because sometimes it could be very tricky. The visual is not as good. So please share, and Phoenix, Mary Lee, will chime in. So
I'll say one thing and then pass it to Amy, but because it immediately reminded me, I'm remembering this case, and I actually do use the fluoroscopy to kind of see where my scope, my cholangioscope or pancreatoscope in this case, is pointing. And that can help guide it around some of these either tight turns or very angulated areas. And that was a challenge in this case because of the room setup and, not having like a dedicated C-arm and the monitors being in different places. But that's one little tip or trick I use.
I mean, what
Yeah.
are yours?
I agree. I also, use fluoroscopy to help. I think, in very dilated ducts like this, sometimes getting a wire access to be able to go over a wire is helpful. I tend to keep all my wheels unlocked when I'm trying to advance. So just to give a little more flexibility to the scope. And then sometimes, changing scope position, whether going from a short to a long position, just to find the way to get the best leverage in order to get the scope in. But it can be challenging if sometimes even putting a device through to make it a little stiffer to try to get around some of those turns will help, like a biopsy forceps or something like that. But
When is pancreatoscopy indicated?
I mean, I think a case like this is a perfect example of an indication. Mapping in a case like this is really important. A total pancreatectomy is a much different operation than taking out a part of the pancreas where the disease is the most prevalent. And if you can go, deep in and prove that there's actually no dysplasia, especially I forget the age of this patient, but in an older patient,
Yes.
you kind of weigh the risks and benefits that, if there's no dysplasia there now, even though it could develop in the future, the better option may be to take out the very diseased area and just monitor and hope that, the part that's not showing any abnormality at this moment in time would remain that way.
Is EUS sufficient for mapping or defining the extent of disease without pancreatoscopy?
I think pancreatoscopy is helpful in that you can actually get microscopic proof. You can, through pancreatoscopy, you can biopsy and you can look under the microscope and be sure that there's no dysplasia there. Whereas, EUS can be very helpful, but I think the benefit of pancreatoscopy is that you can actually get histological mapping.
When you have a cystic mass in the head of the pancreas and a dilated duct and it looks like main duct IPMN, would you FNA the cystic lesion? Does it help?
I think it depends. I think when you have a dilated duct and a cyst and you see projections like this, you can be sure that this is a surgical disease. This part of the pancreas needs to come out. So it really depends, if you're worried that there's a solid component and there's potentially a cancer there, then I would say yes, absolutely. Taking a sample would be beneficial. But I think, I think there's no black and white answer here.
And the AI, what do you guys think about AI for and please, Mary Lee and Phoenix chime in. What do you guys think of a future of AI for cholangioscopy? I know it's much closer, but maybe pancreatoscopy down the line. What do you guys think? Paul, Amy?
I'm no AI expert, but I've seen some great data on AI and bile duct strictures, and I think it will become really applicable in the future, but it'll probably take a long time. We're still going to want tissue, especially if it's going to be for chemotherapy. But AI can help us if it's gets good enough to really show up in real time to help us target our biopsies better. But I think it'll be a long time before we exclusively rely on that and convince an oncologist to treat a patient with just an AI diagnosis.
Mary Lee, what you were going
Well, I agree that I think it's helpful in targeting and actually just training us to be better at identifying suspicious areas. But the real value I see in AI, and maybe I'm just on a different plane here, but I really see AI as being helpful for interpreting our pathology and maybe having it at the bedside where you can take samples and set up slides and be able to I fear for my friends that are pathologists. Is it going to take her job away? Things like that. And in radiology. And I think that's the low-hanging fruit. And also integration of our electronic medical records. But for the sake of time, do we have another case?
Yeah.
We could go on and on, but I'm not an AI expert by any means.
All right, so we have another EUS case, 52-year-old with abdominal pain and a CT scan that showed a main pancreatic duct dilation with scattered pancreatic duct stones, enlargement in the pancreatic head with reduced density, some cystic lesions and calcifications, no fluid collections, but the suspicion was for acute on chronic pancreatitis, pancreatic duct stones, planned for EUS to evaluate further the structure of the pancreas and rule out any mass lesions. So we have Dr. Tyberg here during the case and with several eager onlookers.
Yeah, I mean, I think this is a difficult case no matter where you are in the world. The pancreatic mass in the setting of calcific chronic pancreatitis, I think it can be so hard to determine exactly what's going on. Is this all just chronic pancreatitis changes, or is there an underlying mass or, something else hiding there? And it can be, very difficult to tell the difference. And when we're talking about AI, to me, this is an area where AI could really be helpful in terms of, especially targeting, because as we all know, those calcifications and stones, they cause so much shadowing and they can make knowing exactly where to biopsy very difficult. And, these are always patients that I worry, even if I get a negative sample, that I could be missing something.
Mm-hmm.
As we go through different countries, and we've heard this term, Dr. Riker, the Asian flare. So, Dr. Cork, when you go in and see a patient and they happen to be of different ethnicity, do you have a different mindset? I think, okay, this is an Asian patient. I should think of something different for the pancreas specifically.
That's a very good question. We do think about that a lot here in California. We have a very diverse population, but I'm thinking along the lines of, risks for gastric cancer, some, Southeast Asians with a risk for cholangiocarcinoma. I don't know about specific to the pancreas quite as much that jumps out in the top of my mind. I think pancreatic diseases seem to run across the board, and a lot of that may be due to the fact that people of all cultures might drink alcohol, might smoke cigarettes, and can get chronic pancreatitis. and can get pancreas cancers. So maybe not as much as some other diseases.
Oh, thank you.
Yeah, I would agree. I think a pancreas is a pancreas, and
That-
I think it's true that environmental factors play a big role, which
And yeah, I think
which
we're
cross
getting
board. Yeah.
across the board for everyone. Shall we get to our last case then?
Yes. So we had a 61-year-old with a CT scan, a solid pancreas lesion planned for EUS. And then we had a little more discussion with Dr. Chang about anatomy and techniques for endohepatology evaluation. So he laid out all of the equipment necessary and kind of showed nicely, how to line up the liver and where you would want to go for obtaining portal venous pressures and biopsies.
So sad I missed all of that being in the next case. So I think we're coming to the end. We have just maybe 1 or 2 more minutes remaining. Oh, look at all of us. And just to finish up and ask, is there any last minute pearls or recollections that you would like to share and for everyone? I can start with Amy.
I just think trips like this are such an amazing experience, and I would recommend anyone out there who's passionate about teaching and about learning and about medicine in general to think about participating in a trip like this if you have the option, because it, as I said, it really, restores your faith in why you went into medicine in the first place. And it's just, I mean, selfishly, it's just so rewarding to be able to provide care to a patient population that otherwise wouldn't, necessarily receive it. And also to be able to know that those patients are going to continue to receive that care because of the knowledge that you were able to bring. And also that your patients will be improved from the knowledge you take back with you. So I just think it's an invaluable experience.
Paul.
I think you summed that up perfectly. And I would also just say that I was really grateful to our hosts. They did such a wonderful job preparing the cases, the lectures, the equipment. And we're really lucky to have that opportunity to teach and, like Amy said, to learn from them as well. And of course, I'm very grateful to the AWE trio that I'm lucky to be a part of.
Yeah, me too.
Oh, Phoenix.
I think, we talk about teaching and sharing experience, but Paul said we learned a lot on the trip. Different aspects of endoscopy, the ergonomics of endoscopy. I grew from the experience, and yeah, we're very grateful we did the trip. We became a better person after we came back.
Laurel.
Yeah, I think, the opportunity to go back to Vietnam and hear, how they've incorporated different things after previous courses and get the opportunity to share with a different part of the country some of these techniques has been really meaningful.
And then Dr. Krinsky is going to summarize everything.
Well,
at the end,
I just want to start by saying how proud I am of what we've accomplished during these years doing these global medical outreach missions to Vietnam, especially this one in Da Nang, having Amy and Paul. Paul every time, Amy joined us. Dr. Ken Chang joined us this year. I think Brian was there from Hoag Hospital. We had some hepatology input. This was our third trip to Vietnam, and each time I'm so struck by how powerful these collaborations are with the local physicians and local physician leaders, not just in terms of their skills and the skills that we share, but in the relationships that we build. I mean, it's very powerful and we get invited back every year. I'm so grateful to Phoenix to introducing this possibility to us, and grateful to Sonia and collaboration with AWE and how we all work together with each other, our invited physicians, as well as industry to build on this program each year, and looking forward to what we have in the future. It was so great, you know, to do to see how quickly these physicians incorporate the technologies that we introduce them. I so fascinated by what happened on our first trip to Ho Chi Minh City, where they incorporated EUS and EUS directed therapies immediately. In fact, I think they were doing volumes that perhaps exceeded the volumes that we're doing at our university hospital. So it was quite impressive. And it's so great, those relationships again. And let's keep dreaming for GMOM in 2026. And hopefully Paul and Amy will join us again, and Laurel. So
We have big
see what else.
plans. And at the end of this, we can say that, as always, we're not sharing anything, but we have bigger and better plans. So that's stay tuned, I think, for all of that.
Yeah.
Well, and that is that.
That's a wrap.
That's
So-
a wrap. Thank you
Thank
so
you.
much.
Thank you, everyone.
Thank you so much.